Is Rob Harding. I work in the marketing department here at Children's Hospital and Medical Center, and we're glad to have you here this evening to hear Dr. Hopp's presentation about allergies. A few housekeeping items before we get started. When the presentation is done, we are going to have questions at the end, and we do ask you to hold questions at the end. But when you leave, we'll have a trash can outside the auditorium for things that you'd like to get rid of on your way out. Also, cell phones, we ask you to turn your cell phones down to vibrate or turn them off if you can possibly do that. Also, restrooms, if you exit the auditorium and turn to the left, the restrooms are right there. And once again, we do ask that you hold questions until the end. We're honored to have Dr. Russell Hopp present this evening's program, Allergic Diseases in Children from A to Z. Dr. Hopp is a professor of pediatrics at Creighton University and Director of Allergy Medicine at Children's Hospital and Medical Center. So without further ado, I'd like to turn this evening's presentation over to Dr. Hopp. Thank you.
Thanks. Although he told you twice you couldn't ask questions, I don't have any problem with doing it since we're not a huge audience tonight, and you might have a specific question as we're going along. Otherwise, I'll be happy to stay afterwards. I kind of planned about a half hour or so, and I just kind of want to give you an overview of allergic diseases from my perspective. And even though they're common diseases, I think there's some misconceptions. But at the same time, I just want to put us all on the kind of the same footing. So that way, if you have kids with allergies or you're going to be dealing with allergists other than me, you'll have some kind of common terminology to work with. So when I talk about allergies, I talk about the family of allergies, okay? And most of the people think about probably being a pretty happy circumstance, and then we have an extended family, and I'll explain all this in a second. But unfortunately, I think that allergies are kind of unfortunately not a really happy family. So, and the allergic diseases I'm talking about would be asthma, hay fever, atopic dermatitis, food allergy, and eosinophilic esophagitis. When I talk to parents, I say those are siblings. That's kind of like being a family of 5. So you have 5 different siblings, but they're very closely related. And then hives is an extended family. It's kind of like a cousin, okay? So like a first cousin. And so that puts us a little bit on the same footing. And we're talking about an allergic disease that it's often common to have several allergic diseases in the same child. Well, these are kind of the players in all the allergic diseases and in hives. And so if you understand the players, it gives you a good footing for understanding what I'm going to be talking about. So we have, over on the far right, we have the IgE antibody. And that's a specific antibody that's going to help, or unfortunately not help, your child to have their allergic disease. So it's going to help the child to have the allergic disease, which is what we don't want, okay? In the middle, we have a eosinophil, and the eosinophil is going to show up in the tissue, or it's going to show up in the bloodstream. So we get a blood count, and we see the eosinophils are high, and then it makes us think about allergic diseases. But if you have too many eosinophils out in your tissue, in your nose, in your skin, in your lungs, in your GI tract, those eosinophils do damage. And so part of the damage and part of the process of an allergic disease is having these eosinophils out into the tissue. And that's unfortunately where we don't want them. And then the third player is the mast cell. And that's the mast cell is also in the tissue, but it's kind of a good thing in the tissue most of the time. It doesn't really do very much. But when we have an allergic disease, and I'll show you in a second, all these 3 things come together. And this is how they come together. The mast cells are sitting in your nose and your lungs and your GI tract. We have billions and billions of mast cells. And they do some positive things for everybody. But they don't do a lot of bad things unless you have an allergic disease. If you make specific IgE to an allergen, then that IgE goes and sits on the mast cells in the tissue, your nose, your lungs, your skin, wherever. And when you're re-exposed to the allergen, dogs or cats or whatever you're allergic to, depending on the disease, and we'll talk about that going through, you release chemicals that cause allergic symptoms and pull eosinophils into the tissue. And those eosinophils are going to live there for about a week. And there's going to be wave after wave after wave of eosinophils. And over many months and years of having eosinophils in the tissue, that's when some of the chronic inflammation occurs in patients with allergic diseases. So those are our players, all right? Now, the the commonality and kind of everybody kind of focuses on is what the IgE antibody is. And so there's two ways of measuring IgE. We can measure it in the blood, and you have to remember the IgE is made made in lymph nodes and then goes to the blood, but then wants to go out into the tissue. So we can measure specific IgE in the blood, or we can do skin test, which is determining if there's IgE sitting on mast cells in the skin. And the skin is therefore the substitute for the nose, the lungs, and the GI tract. It doesn't cause a lot of trouble in the skin unless we have like atopic dermatitis, but if we use the skin as a replacement for the nose tissue or the lung tissue. It's the same IgE antibodies. They're sitting on the mast cells. They release histamine when we skin test, and we get the positive response. It's the same information. I'm not really getting any more information from the blood test compared to the skin test. And in fact, the skin test is actually a little bit better, a little bit cheaper, and a little bit quicker. But everybody has some notion that the blood test is better. And it's really not a better test. It's just the same information in a different place. Okay? Now, the next thing that people have a little bit of trouble figuring out is what a positive test means versus having a disease. Okay, so this kind of shows that. To be sensitized means that you have a specific antibody present. That's it. Present in the blood, or it's positive skin test in the skin. That you stop right there. In order for me to say you have an allergic disease, then that IgE is causing a problem that the doctor tells you. Your child has da-da-da. And then this specific IgE is causing that problem. So being sensitized is not a good thing, but doesn't necessarily make a disease. It's just a fact. You are sensitive to dog. You are sensitive to peanuts. You're sensitized. You have a positive test. Now, to make the diagnosis of a food allergy or an environmental allergen, I have to put that IgE information into context of what's going on in a particular child. The blood test or the skin test doesn't make a diagnosis. It just says you're primed, you're ready to go, maybe that particular allergen is a problem. So my job as an allergist is in part to try to figure out the association of the specific IgE that I gather to what I think the child has as an allergy. Do you have a question? Sorry, my fault. Okay, so of the allergic disease family I talked about, the IgE antibody is either more important or maybe subtly less important information. So even though we have the allergy information, a lot of times it's gathered for me by the primary care doctor, or I may gather the information. I'm using it to help decide how to take care of the particular child who's in my clinic. So for hay fever, allergic rhinitis, the IgE is always positive to something. It's either relevant or less relevant. It may be that your child has a dog, and as far as we can figure out, the dog never causes problems. And then maybe they're having terrible trouble in the spring and they're allergic to trees. So it's relevant for the trees, but less relevant for the dog. But there's a positive test, and I have to put that into correlation. How does each allergen associate with that child's nasal symptoms? For food allergy, it's 100% relevant. So the food or the foods that cause a problem are relevant. And there may be foods that the child is allergic to or sensitized to. I use the same term, and have nothing to do with that child's food. The child can eat the food any time they want to. So it's not a food allergy. Positive test, not a food allergy. In asthma, in children especially, as we get a little bit older, about 80% of them are allergic to something on the skin test. But sometimes it's a challenge to exactly figure out if they're relevant 100% or not. So is the asthma 100% caused by an allergy? Probably not. In fact, for most kids, it's more viral infection. But as we get older, most kids have positive skin tests. Kind of same thing for atopic dermatitis. We have a disease on the skin, it's on a chronic basis, and the kids often have positive skin tests to environmental allergens or maybe even food. And it's my job to figure out whether those are relevant or not. Positive, yes. Relevant, maybe. And then for eosinophilic esophagitis, which is really uncommon and maybe a new allergic disease for some people in here, it's kind of the same situation. Many times it's a positive test. I got to figure out the relevance of those positive tests to the disease. How do I mix and match, so to speak? Is the disease being caused only by an allergen or maybe just bothered by the allergen to some degree? So we'll talk about the diseases, and I'll again talk a little bit about how IgE fits into each one of them. So if we're talking, I think asthma is probably the most common disease, allergic disease that people are familiar with. It's not the most common. Actually, hay fever is more common. But I think it's a little bit more significance as far as chronicity and possibilities for problems. Strong genetics. So we always ask about family history. There's something going on in the lungs that's intrinsic to being asthmatic that non-asthmatics don't have. And I can spend hours and hours talking about it, but I'll show you a picture in a second. Their lungs have there's a differentness to their lungs that is not in a non-asthmatic child. It's just the way it is. They're more, in younger kids, it's more often boys than girls. But after 10, it's more girls than boys. So by the time you get to puberty, or by, 18 or 20, it's about an even distribution between boys and girls. Allergy is common, and then I have to figure out, is the allergy relevant to their lungs, or do they have hay fever also? And then those allergens are relevant to their nose. Okay? So the positive tests that we do, and then I have to put those into perspective. How do they affect the child's lungs? If you go to grandma's house and she has a cat and you start wheezing at grandma's house, guess what? That's a relevant allergen. But other allergens may not play as much of a daily or even a regular role in that child's asthma problem. So viral illnesses predominate as far as triggering mechanisms are concerned. So when children have wheezing, I always say it's not a normal thing to wheeze, and that's a common symptom. Chronic cough is also a common symptom. Some kids never wheeze. They just have a chronic cough with their asthma. So their lungs change enough, but not enough to wheeze, and then they just have a chronic cough. So with chronic coughs and recurrent wheezes, those are a symptom of asthma. There really is no definitive test. And so I think that's an important thing to know. I gather lots of information. I'll show you what that is in a second. But at the end of the day, I can't 100% say your child has asthma. It could be 98% or 95%, but there's no test that says absolutely 100% ever that your child has asthma. Now, at the end of the day, end of the week, end of the year, end of their life, they had asthma and we've been treated it correctly, etc. But I've never can do it an absolute 100% pure test. The nice thing is we can outgrow our symptoms, but we don't really. The potential for asthma stays there. Now, again, when I talk about the intrinsic difference in asthma, it's something that's there. It's the way their muscles and their lungs react. And I kind of use the analogy of a thumb that got hammered with a hammer. And for the rest of your life, it never gets better. So you have to walk around like this for the rest of your life. And you can think about if you bump into that or bump into that, it's going to hurt. Well, that's the difference in their lungs. They're super, super sensitive. And there's something intrinsically different about the child with asthma's lung, as is the adult with asthma. And that difference I can't change. I can modify it a little bit. I can't make it go away. When it wants to go away, it goes away. And I have no control over making it go away. So at the end of the day, at the end of the clinic, and sometimes maybe takes several months, I'm gathering information on each visit and and for the history, the clinical history, the family history. Is the family history of asthma? The examination, is there wheezing? How did they do with asthma therapy at home in the past? Maybe they already came to me with medications. How did the child respond to that medication? Asthma therapy works for asthma. It doesn't work for something else, okay? We can do breathing tests, which is really, really close to saying, yes, you have asthma, about as close as I can get based upon the test. We can do a chest x-ray. There's other tests we can do. Skin testing doesn't prove asthma. It just says you're sensitized. And then you put that into context and say, yes, when you went to your grandma's house and you wheezed and you're allergic to cat, that's not normal. Wheezing wasn't normal. You're allergic to cat. Probably you have asthma. As close as I can prove it for a 2-year-old child, okay? Maybe I put the child on asthma therapy and they got better. The symptom of wheezing and coughing got better. And we take them off and it gets worse. So sometimes the therapy, which works for asthma, works because it's asthma. And then we follow that up on each visit. And most of the time, within a visit or two, we pretty much come to conclusion. But there are kids once in a while, it takes a little while to ascertain that they have asthma. Again, I want to remind you there's no 100% asthma test. We can get lots of information. We just can't get all the way to the end of the line and say, yep, we crossed the line. I'm 100% sure. I never can go back. Most of the time we don't, but we just consider other options as we go. Treatment is based upon therapy, severity. Everybody gets a rescue medication. And then based upon the significance of asthma, then there's what's called maintenance therapy. And that's something they take every single day on a long-term basis to control asthma symptoms and actually to change the severity of that smashed thumb just a little bit. Not very much, because I can't change it 100%, but I can kind of calm it down a little bit. We adjust their medications as the child is doing better, and then basically we cautiously will step down or stop therapy after many years probably of continuous therapy, and we can talk more about that. But just the point being is that this is a chronic disease, and it doesn't really have days that are, some days are a little bit better, some days are a little bit worse, but it never really goes away. And that intrinsicness of the asthma never really goes away until somebody decides that it does, and I don't have any control over that. Okay, we'll talk about allergic rhinitis. This targets the nose and often the eyes during certain times of the year. Everybody's probably either has hay fever or knows somebody who has hay fever and knows they're miserable in the spring or miserable in the fall. So the indoor allergens are more of an issue with younger kids, or if it's in the winter months, we're worried about more indoor allergens. As we get outside and the child gets older, we're starting to worry about pollens and molds, etc. You can see all the different nasal symptoms. Some children have some and some children don't. Some people have lots of eye symptoms. Some people have no eye symptoms. So it's kind of you have all these mix and match opportunities, and each child kind of gets to pick what their major concern is. So some of the allergens, dust mites, of course, pets, molds, pollens. There's different pollens based upon the year. We've already had our tree allergens, cockroach allergens. And I can usually correlate the positive skin test for pets and pollen really good. So what time of the year do you have trouble? I can pretty much tell you what you're allergic to. Or do you have trouble around cats and dogs? Tends to be pretty obvious. The dust mites, the molds, and the cockroach tend to be a little bit more subclinical. It's more of a persistent symptom rather than dramaticness, like when you go out in ragweed season and your eyes swell shut and you start having sneezing attacks. Don't have that dramatic a symptom with dust mites as a rule. So a treatment we try to avoid as much as possible. This is sometimes difficult to do depending upon circumstances. There's a hierarchy of medication we use. We can use simple saline, nasal sprays, although little kids don't like that. Antihistamines, nasal steroids, decongestants can be used. There's medicines like Singular, leukotriene modifier it's called, it's pretty common. And then for more difficult kids, we use allergy shots. Okay, we'll switch gears to a little bit, which is this is probably the most straightforward allergic disease. It's a food, 90% of the time, a food, something bad, you eat it and something bad happens. If you don't eat it, nothing bad happens. All you need to do is avoid it, and you don't have the disease. You still have the potential, so avoidance is continual and necessary and important, but once you stop eating that allergen, that food, the disease goes away. The potential disease goes away. About 8% of kids have a food allergy, and this has probably tripled or quadrupled in the last 20 years. Peanuts used to be less than 1%. It's now more than 1%, approaching 2%. The symptoms are generally almost always reproducible. So if you're eating a regular food and getting highs once a year, it's probably not that food. So the symptoms of the food allergy are reproducible and repeatable on the re-ingestion of the food. So the symptoms would be hives, generally, 90% of the time hives, and generally soon after ingestion, not 2 days ago, not a month ago, within 2 to 3 hours. Sometimes kids have partial anaphylaxis. They get hives, swelling, maybe coughing. That's their immune system, their allergy immune system just didn't get accomplished what it could have done, which is anaphylaxis. That means you could die from eating that particular food. Anaphylaxis means you're on your way to death. You better take your EpiPen, better get to the emergency room, bad things are happening. And for as far as food allergy concern, a food goes in, something bad happens. And it's reproducible, it happens every time, the treatment is figuring out what it is, and most of the time it's pretty straightforward, and at that point, avoidance. And I'll talk a little bit about how to follow it. I don't intend to confuse you, but there's a little bit of a hierarchy. There actually are some kids and people who only get blood pressure changes from their food, very uncommon. 90% of people get hives. 90% of people get itchy hives, or some severe itching or problem when they're eating the food. So but there is kind of a differentiation in depending upon what the food is and some other circumstances. But 90% of the time, it's dramatic and it involves the skin. So some of the common foods: peanuts, tree nuts, milk, eggs, soy, wheat, and shellfish. And just a reminder, peanuts are not tree nuts. Totally separate allergens, have nothing to do with each other. Now, when I have somebody who's allergic to peanuts, I usually don't let them eat tree nuts because they're little and they don't know the difference. But botanically, they are not even related whatsoever. Peanuts are related to soybean. They're legumes. As far as treatment is concerned, it's strict avoidance, maybe strict avoidance for a year, maybe strict avoidance for 100 years. And it's my job to tell you how long. So if you're allergic to peanuts today, you're not eating them for a year. We'll talk about it in a year. We'll monitor the degree of allergy in a year. We'll make a decision what to do in a year. It may be another year of no eating peanuts, and that may go on for 100 years. Okay. While we're waiting for the food allergen to go away or never go away, we always have EpiPens. So you have an EpiPen at your house and at babysitters and at the daycare and at school. Everybody gets an EpiPen, and the school has an action plan, and the school knows what your child is allergic to, and the school has an EpiPen for your child in his or her name. Okay? All the schools in Omaha and Nebraska have an EpiPen that's not for your child, unless your child didn't bring one, and then they have one. But the goal is everybody has an EpiPen with their name on it and what they're allergic to. How about outgrowing? Everybody wants to know that. Milk and eggs, very, very good. Tree nuts and peanuts, not very good. And all the other foods are better than peanuts and nuts. But those are the 4 foods or 5 foods we know, 4 foods we know a lot about. Milk and eggs, most of the time you outgrow it. Last little disease I want to talk about, little in the effect of it's not little in its importance, but little because it's not very common. 10% of Omaha children have asthma. 25% of Omaha kids have hay fever. 7% of Omaha kids have food allergies. Okay, this is 1 in 10,000, but it's becoming a more common disease. As a matter of fact, we have a clinic here at Children's that we just see these kids in once a month with this disease only. It's called eosinophilic esophagitis. Everything that I talked about with asthma, with inflammation and eosinophils happens in the esophagus. Everything I talked about hay fever with eosinophils and congestion and runny nose happens in the esophagus. So it's an allergic disease that just picked the esophagus versus an allergic disease that picked the lungs. Okay? So each allergic disease gets to pick where it wants to go. Sometimes you have 3 or 4 allergic diseases. You have asthma, hay fever, eczema, etc. There's a progression of symptoms depending upon the child's age. And again, it's an uncommon disease, but if your child has that, we can talk about it more. Little babies have a very drastic difference in symptoms than a teenager. So we have to think about how to deal with it based upon age of the child. Kids that come in with it when they're teenagers get food stuck in their esophagus, and we have to take it out. You have to diagnose it with a scope. You have to have the gastroenterologist help us diagnose it. So if I have an asthmatic child who's having trouble swallowing, then I'm going to send them to do a scope because I want to make sure they don't have a second allergic disease, eosinophilic esophagitis. So we can do a treatment protocol. Some of these kids take an elemental diet. Some of them swallow steroids, the same medicine they take for their asthma, they swallow. They'll take a reflux medication, and they'll be followed in my clinic like an asthmatic every 3 to 4 times a year. We'll do scopes once a year, and it's a chronic disease. If something makes it go away, then that's great, but I can't make it go away. I can just control it. I can put it in a position where it's stable. I can't make it go away. I just can control the disease. Okay, and finally, atopic dermatitis. Oh, I think we have one more process after this, but this is the last family member And just like we don't talk about this, we don't talk about intrinsic problems with other diseases, but there's problems with people with hay fever have a difference in their nose. People with eosinophilic esophagitis have some difference in their esophagus. We can't measure these differences easily. It can be measured in the lung quite easily, but in the other organs it cannot be measured. But there is an intrinsic skin hyperresponsiveness. The skin is different if you have atopic dermatitis. You lose lots of water. The water does not have, the barrier to water loss is not correct. And so water is lost. You lose water. You evaporate water out of your body, onto your skin all the time. The confusing thing is kids are often sensitized to foods. Positive skin tests or blood tests, atopic dermatitis. Immediately what people want to do is presume the foods are causing the atopic dermatitis. What probably happens is the skin is open. Okay, it's not intact. And so you eat in the house, everybody's eating, the child is in the house eating around the food, and the food gets on the skin. It penetrates the skin better because the barrier is gone. They make more antibodies. So this is not a food allergy disease. It's an allergic disease that often has food sensitization. And it's not causing the atopic dermatitis. It's just associated with having atopic dermatitis. So it's uncommon for a food to be the reason. Doesn't mean we don't do allergy testing and try to contract the foods if we need to in a very severe case, but we can't cure it by stopping a food. If you have food allergy, you don't eat the food, you don't have the disease. We're done. In this disease, it's part of the process of figuring out how to make your atopic dermatitis better. I can't cure it by removing a food. Other allergens may be an issue too, dust mites or dogs or cats, etc. You're in an environment, your skin isn't intact, these allergens penetrate, you develop more positive allergy tests. It's not the cause, it's associated phenomenon. So we want to hydrate the skin, we want to reduce the itch cycle by keeping the skin moisturized. We use topical steroids, antihistamines, antibiotics. There's other medications that can be used. Light therapy, for example, is used. This is a difficult disease. It's kind of like asthma, but you can see it. Okay, asthma you can't see, you can wheeze, you can hear it, but this is the same process that's going on in the lungs: inflammation, redness, just the skin not being normal. You can see it on the skin, and that kind of freaks everybody out because it's so obvious. But the same process is going on in the lungs. It's just not normal tissue, but you can see it on the skin. Now the final disease, and this was this cousin, okay? And so hives, painful, itchy, terrible, everybody gets immediately want to know what you ate, what you're allergic to. That's the first question. My child's getting hives. What are they allergic to? Well, it's a cousin disease. It's not an allergic disease per se. And so we talk about chronic hives being there for more than 6 weeks. And that seems like a long time, but by definition, that's what chronic hives are. Or recurrent hives would be it's been returning off and on for 6 weeks. Acute hives means you got it today, you didn't have it yesterday, and have it 3 months ago and 6 months ago, but it's there right now. Okay, and so when the children come in with hives, it's generally more acute than chronic. I tend to see more adults with chronic hives. Been there 6 months, 6 years. People haven't figured it out. So when I'm breaking down the reasons for hives, I will start with is there a potential simple explanation? I ate peanuts, I got hives. That's a simple explanation. Okay. I played with the cat, I got hives. That's a simple explanation, and I can do a skin test and show that. Okay. Or I took a medication, I took an antibiotic, and I got hives while I was taking the antibiotic. Fairly straightforward. So food, medications, very intimate exposure to an allergen like a pet might all be a trigger for hives. That's it. We're done with IgE. At that point, we're done with IgE. We can't explain it with IgE if we can't explain it pretty easily. So you had hives for 6 years or 6 months, and you can't figure out an allergen. Guess what? It probably isn't. Okay. So then we start looking for alternative reasons. Is it a physical urticaria? Urticaria means hives. So heat, sun, vibration, pressure, exercise, these are all physical things. Scratching, real common thing to see as kids scratch their skin. They break out in hives. That's called dermatographism. Autoimmune means that you're attacking your own mast cells. Mast cells in your skin have histamine. Histamine gets out, causes hives. If you're attacking your own mast cells, then you're going to get hives, called autoimmune hives. And I see it 2 or 3 times a year, especially adolescent females, but mostly adult people. Infections, viral infections, and acute infections, which commonly trigger hives. If you've had hives for 6 years, it's probably not an infection. And idiopathic means I don't know. I don't know what's causing your hives, okay? And I probably, if you have hives for 6 weeks, I'm guessing it's idiopathic 70 to 80% of the time. Again, this is not a usual pediatric problem. But I want to give a little bit of focus because everybody automatically thinks it's a food, it's some allergy. And no, most of the time it's not. It's involving the mast cell. It's releasing that's causing histamine release, causing the hive, bumping up on the surface. But the mast cell is the process, not the antibody sitting on the mast cell. It's not an allergen that we can easily identify. It's not a cat or a dog or a food. Okay, treatment is identify the cause if possible. Antihistamines, more antihistamines, more antihistamines, more antihistamines, and often just time. Okay. Now there's some other therapy that I didn't talk about, but it's uncommon to use it in kids. More of an adult problem. But usually high-dose antihistamines for a couple weeks resolves most of the hives. There's physical urticaria, like the scratching phenomenon I talked about. It may take a couple of years to get better. Daily antihistamines are what they have to take. Okay, with that in mind, I kind of maybe put you all on an even footing for some of the concepts of allergic disease. And we got plenty of time for answering questions. I know there are people possibly on web, but they can't ask questions. So I'll let you ask questions for them, and please feel free to ask as many. Be particular about a circumstance. If you have a specific question about your child or anything any information about your child, or if you want to ask very general questions, that's why I'm here. So, sir.
Yeah, I'd just like to know, so what causes food allergies? What are some things like you could do to prevent a food allergy to happen in a kid? I mean, if there's certain things that you should feed your kid so he doesn't get food allergies.
Right. Well, I'll just repeat the question in case people are listening. The question, which was extremely appropriate, is now we have child number 1 with a food allergy. Now child number 2 is coming along. How do we prevent that? Would that be a good way of stating that question? Okay. And what we thought for a very long time, and it seemed to make sense, is if we didn't eat the food, we wouldn't be allergic to it. Now, so here's the 1-month-old, and the 2-month-old, and 3-month-old, and 4-month-old, and 5-month-old, up to 12 months, and maybe 2 years, sitting and watching everybody eat peanut butter sandwiches and eating scrambled eggs, and we just said no. We know that peanut butter, we know that eggs, we know that milk, we know that tree nuts are highly allergenic. We won't eat them. We won't put them in his or her mouth. So magically at age 2, they won't be allergic. Okay, didn't work. So what we feel, without a lot of reverse evidence, is that we better feed the kid those foods really early. So milk, if the child isn't getting milk in a bottle, then it should be getting milk in a bottle as supplement within the first couple months. Okay? If the mother isn't eating scrambled eggs or eating eggs and the child isn't eating eggs, they should eat eggs by 6 months. Okay? And the magic one is what to do with peanuts. And in theory, they should be eating peanut butter fairly early in life. And the studies are being done to say when, but it's not been implemented in large fashion. So if you talk to your pediatrician, they're not going to say, put your 6-month-old on peanut butter, 6-month-old on peanut butter. But in theory, that's what happens. So here's the thought. If it goes in the mouth early, good things happen. If it goes on the skin early, bad things happen. And you make allergy antibodies. Okay? Pardon? Yes, they're making antibodies in utero. So I'll tell you the story in a second to explain that. So in theory, if we get the food in the mouth, we develop tolerance. If we don't get the food in the mouth and it's surrounded in peanut butter cloud for 2 years, they're going to be allergic to it at a higher degree. So the thought will be, and the thought should be, is we're going to get these foods into the kid quicker, earlier. That includes wheat, that includes soy, includes peanuts, includes tree nuts. It's hard to do tree nuts because they're big. Eggs and milk, for sure.
Is like in the last few years, I've been getting allergic in like fall to like hay fever, whatever that is. It causes me to like my nasal passage to block up.
Mm-hmm.
And my doctor, my family doctor, told me it was because I'm in construction and I've exposed myself to a lot of dust and a lot of airborne particles, whatever, and that might be why I have allergies now.
Right. I would say the majority. The question is why do adults develop allergy and didn't develop them as kids? Basically, I would say that most people that are going to have allergic rhinitis are going to have allergic rhinitis by the time they go to high school. It's uncommon to wait into your 20s or 30s to have allergic rhinitis. If we're just talking about a nasal allergic rhinitis problem. If you've never been exposed to an allergen before, then it may take exposure. Maybe you never were exposed to cats your whole life, and then you got married, your wife brought a cat to the house. Maybe that's when you develop cat allergy, for example. But most of the time, the development of allergy is early because none of these allergens all these allergens are very prominent in our environment. So we don't tend to wait till we're 20 or 30 to have the problem. Do other cofactors, dust, dirt, things like that contribute to the development of allergy? The answer is no. Either you just waited later and it has nothing to do with the kind of work you do, or maybe you just had them to a lesser degree, but it's uncommon to wait till you're 30 to develop hay fever. Just it happens once in a while, but it's not a common thing. The genetic potential is there. Why you waited isn't related to anything other than just the timing that it was. So the story I wanted to tell you about. So I've seen a few babies that on day 1 drank milk in the nursery, had anaphylaxis. So the point to that story is that you can be allergic on day 1. That day when you were born, you were already allergic to milk. Now that's the only allergen I've seen. I've seen eggs at 6 months. Okay, and I've seen peanuts at 4, 5, 6, 7, 8 months. Because people just have been avoiding peanuts, because that's been the recommendation, which has been wrong. And people don't tend to give their little babies eggs, but you give babies milk, right? Either you're going to breastfeed or you're going to bottle feed. So on day 1, that baby, I've had a couple of babies that got milk in the nursery, tried to die from anaphylaxis. That proves that they were allergic right there, day 0, at birth. So food can cross the placenta, and you actually can develop an allergy antibody to food in utero. That's how early it happens. So you can't be too young to be allergic to anything if you can be allergic to milk on day 1. Okay. Now, not worried about dog on day 1. I may wait a couple months to worry about that. Okay. But you can make antibodies in utero, and food being almost the only allergen that I'm worried about in a tiny baby. So, other questions? Great questions. Yes, ma'am.
So that's individual.
Yes, individualized. The potential to be an allergic person is ingrained in our genes, and we don't have any clue what it is. No clue. Okay, it's just there. But then you pick what you're going to be allergic to. It's not common to be allergic to milk at 1 day of life. It's not a common thing, but it can happen. So the milk in the mom's diet came across the placenta, even though it was chopped up with digestion, but the baby saw enough milk protein to say, I don't like it, I'm making an antibody. Oh, when I got milk first day, I had an allergic reaction. Okay? Doesn't happen very often, but when the child has an allergic reaction to eggs here, well, when did he or she make antibodies? I don't know. Maybe in utero. Or because everybody was eating eggs in the house, and finally baby grabbed a handful of eggs and stuck it in the mouth, had an allergic reaction. Okay. I can't back up and figure out when it is. It is when it is, and then we deal with it going forward. But the genetics of it isn't that hard that I can say, Yes, you're going to be allergic to eggs. You're going to be allergic to peanuts. There's not hard enough data for that. Right? Even family data. So, the background. There's some data on peanut allergy. About 9 to 10% of siblings of peanut allergic kids are allergic to peanuts, or sensitized to peanuts anyway. That's probably not different than the general population. If you just skin tested everybody in the United States, about 9% of them are sensitized to peanuts. But not everybody's allergic to it, just sensitized. Okay, different story.
So if child number 1 has a food allergy, it's not necessarily true that child number 2 is going to have an allergy because it is individualized.
Correct. Correct.
I've always heard it's likely that child 2. That's not. Okay.
No. But I kind of rephased the question because the thought process was if we didn't, well, everybody's got to drink milk or breastfeeding, so they're going to get milk. But we didn't eat eggs until 1, and we didn't eat peanuts till 2. Well, while we were waiting for nobody to become allergic, everybody was becoming allergic because they got sensitized in utero, and they got sensitized in their skin in household. So the cloud of peanut and egg stuff was floating around, and they were walking through but not eating it. The natural way of it being exposed to a food is in your mouth, not on your skin. Okay, and that's how we think antibodies. So peanut allergy went from 0.1 to 2% in 10 years, while we are not feeding kids peanuts, waiting till 2 years. So the thought is we need to feed kids earlier. Doesn't mean it's 100% protective, but that's the thought that it's going to be better than what we're doing, which is don't eat it till 2. Okay. Yes, ma'am.
Allergy, can the reactions be different? Kind of manifest themselves in different ways? Like, could they get not hives, but hives one time, and maybe some kind of gastro problems one time?
And probably 90% of times, hives are going to be part of it. So when I'm dealing with the food allergy that's not painfully obvious, I'll allow for some GI symptoms on occasion, but obviously it's not it's more of a hidden allergen. You're eating the food on a regular basis, nothing is really happening. It's dramatic. When I see a food and you vomit, you get hives and you vomit, guess what? You got a food allergy. So it depends. So it kind of depends upon volume, how quickly they ate it, how well it was cooked, what the protein is, maybe other circumstances. I mean, there's a multitude of possible circumstances. But as soon as you have you vomit and you got hives, then there's your food. There's your GI symptoms and there's your skin rash at the same time. So that's the obvious bad food. But the very subtle food with GI symptoms on occasion, and that's not the first thing I think of, but I may go there maybe the second or third visit if we're not making any other progress. Okay, with the thought is if you have atopic dermatitis and your stomach hurts too much and you throw up, then you're going to get scoped because I'm going to worry about eosinophilic esophagitis. Okay. Oh, eczema.
Okay.
Yeah, eczema. It's same term. Atopic dermatitis is eczema. But eczema is a little bit of a broader concept. Atopic dermatitis would be the proper allergic disease terminology. Right. Questions?
Infections if they're not treated right away, or like for the nose.
Oh yeah, right. There's a lot of sidebar problems with chronic allergic rhinitis, sinus infections, ear infections, right? So it's everything. Everything's in a very tight, compact space, and the nose is basically the hallway, and then there's a passageway down to the ear, passageway to the sinus, passageway to the ear, passageway to the sinus. So if this hallway is full of congestion and gunkiness, and then this passageway doesn't work very well. That's the passageway to the ear. Okay, so if there's chronic allergic rhinitis here, often gives you concomitant other problems, ear infections, sinus infections, big adenoids. So everything is in a very small space. But a lot of stuff is in a real small space. Yeah. So good question. Yeah. Other thoughts, ma'am?
My question is kind of like hers, and I'm not sure I understood the answer, so I'll ask it my way. Our son has a milk allergy. He's one of your patients, and he's one we thought it was a day one kind of allergy.
Right.
He had how we figured it out was he had the hives, the itchy, runny nose, sneezing, vomiting, all that thing. Well, then about 18 months, he accidentally got something in church nursery, and we had to go to the emergency room, but his reaction was different that time. It was like swelling up, airway closing.
Right.
About 6 months ago, he didn't consume anything, but again, someone else using a macaroni and cheese rag that they cleaned their kids with, cleaned his skin, and he automatically broke out. So do reactions, are they different? Can they, or will they be different every time? And is a skin reaction like he just had 6 months ago indicative that his allergy is just as bad as when we went to the emergency room at 18 months?
Right. The point would being, you know, I've seen kids that have put the food in their mouth within 10 seconds, vomited, and got hives from the vomit. Okay. So once you're allergic to the food, and you're still allergic to the food, and your blood test says you're still allergic to the food, and I'm saying you're still allergic to the food, then anything is possible. There's mast cells everywhere. They're in your eyeballs. If you put milk in your eyeball would swell. So it just depends upon good luck, bad luck, how it was exposed, if it was partially cooked, multitude of factors. And you know, there's kind of some concept if you had allergic is there an acceleration of allergic reactions? And there's been some concept that that's true. If as long as you stay allergic, each time you have an allergic reaction, it's going to be worse. You know, I just say we're not going there. You know, we're not going to try that experiment and try to figure out. And so, I don't know why people would deliberately eat peanuts 5 times to see if their allergic reaction would get worse every time they would eat it. So you'd have to do that kind of experiment to prove it. It's more what they call anecdotal. Just we think that might happen, or it seems like that happened. But to do a study to prove an accelerating badness is hard to do. Now, I talked about the hammer in the nose. I mean, the lungs. I talked about, you know, the bang hammer in the lungs. If you have asthma and food allergy, that's not a good combination. Okay. If you have food allergy, you can get bronchospasm. But if you have a food allergy and you have asthma, that's a double problem. Because now your lung really knows how to get asthmatic, and then you had an allergic reaction that caused you to have a severe bronchospasm in an asthmatic person. So sometimes that's a cofactor. All right. Depends on how high the IgE antibody is. The IgE antibodies start at 0 and they go to 1 million. If you got 1 million antibody level versus a 4 antibody level, that's worse. So just a little bit of milk sprinkled on your skin might get you in trouble because it very quickly it's absorbed. So it can be from time to time, but there's so many variables it's hard to really sort it out. Okay, so hopefully I answered your question and the circumstances of your child. Just bad allergen and too high of an antibody and not a good combination to mix and match.
The positive outlook is IgE
level, right?
Down,
right.
Then that means we're getting better.
We're getting better. So the outgrowing concept is we started off with a positive skin test and a history. Drank milk. Got milk on him, had an allergic reaction, positive skin test, I proved allergy. That's it, 1 year of avoidance. In a year, I'm going to do a blood test. Why? Because it gives me a number. 10, 20, 30, 50, 70, 100. So I know what that number means for prognosis. How quickly or likely is the number going to keep backtracking to a lower number? So for milk, it's 2. If it's 100, it's not 2. If it's 50, it's not 2. If it's 4, it's closer to 2. I'll be more optimistic that, yes, we're going to outgrow that. I don't know when, but we're going to be more optimistic. So the next year, it's 2.5. Not 2, but it's getting lower. Okay? If it's 100, and the next year it's 100, and the next year it's 100, guess what? We're not going anywhere. Okay? We're not going anywhere in that direction. So I want to have it go down a little bit, or maybe a lot, but I'm not going to do anything until that level is 2 for milk. Because the studies have been done, I know what the numbers mean, and I know I have a better chance of passing at 2, but not at anywhere near at 100. And really 2 is where I'm going to do the challenge at. So the numbers want to go down with time. Or they may not. With peanut, it may be 50, and maybe 50, and maybe 50, it may stay 50 forever. It may never go down. So Other questions? We have 2 more minutes.
My little girl has an egg allergy, and the allergist said that we could give her eggs if they're baked in things. Is that typical that with eggs, and then we're avoiding for a year? But
there's 2 parts to that. One, probably most kids who are egg allergic tolerate baked egg. That's not true for milk. But most kids who are egg allergic will tolerate baked egg, and it's almost always they ate the egg at 12 months. I don't know why 12 months is the magic number. It's not the magic number anymore, but that's the magic number. They had an allergic reaction, and the parents will say, I'll say, well, you know, we ate the scrambled eggs, had an allergic reaction, the skin test was positive, but they'll say, she can eat cakes and cookies just fine. Well, guess what? They're not eggs. They've been cooked. They're baked eggs. So I'd say most of my egg kids can tolerate baked eggs. What we think is that, let's say the number is here, we start giving them baked eggs, we push it this way quicker. So we really want them to eat baked eggs. That's what we think. Okay? Now, it's true for milk sometimes, not always. It's never, ever true for peanut. We never, ever touch a peanut in any way, shape, or form. Cooked, boiled, nuked, I don't care what you do to it. You can't do it. Can't eat it, can't touch it. So. Okay. Other questions? All right, well, thanks a million for coming and giving up a very nice evening. And I'll be happy to hang out for a couple more minutes if you have any other questions. Thank you.